So thank you again for joining us today for the Lewy Body Dementia Association's webinar, Caring for the Healthy Caregiver, Strategies for Healthy Living and Coping. I'd like to introduce our two presenters for today. Our Dr. Gary Epstein-Lubow is an attending psychiatrist in Providence, Rhode Island, and the assistant unit chief on Butler Hospital's inpatient geriatric psychiatry unit. His research and teaching focus on family interventions for individuals with neuropsychiatric illness. And he completed training in general psychiatry, geriatric psychiatry, and psychological treatments research at Brown University. He's currently appointed to Assistant Professor of Psychiatry and Human Behavior with a secondary appointment in Health Services Policy and Practice at the Alpert Medical School of Brown University. So welcome, Gary. Thank you so much for coming. Angela Taylor is also our Director of Programs for the Lewy Body Dementia Association, and she's co-presenting today. She joined Lbda originally in 2004 as a member of Lbda's Board of Directors when she was a caregiver for her father who had Lewy Body Dementia. Angela oversees all of Lbda's programs and services and serves as liaison to our Scientific Advisory Council and the Lbda Community Discussion Panel, who have been super helpful in getting this caregiver topic together. So thank you all very much for joining us today. We have a big group, and I will go ahead and pass the presenter slides over to Gary to get started.
All right. Are you seeing our front slide? And can everybody hear me okay?
Gary, are you sharing your slides?
I am. Are you not seeing it?
I don't think so.
Okay, hold on. Now, are you seeing it?
Let's see. Yes, I believe we see your desktop.
Okay,
You're
great.
good to
You
go.
can hear me.
Yes.
All right. Thank you, Elizabeth. And thank you, Angela, for inviting me to participate. And I also want to give particular thanks to Butler Hospital for supporting me and to the caregivers that helped organize this webinar. The reason we have a caregiver panel at the backside is to show that everyone really finds their own way. And I learn as much from listening to caregivers, learn newly each time. And the tough task is really accepting your own situation. So for those of you who are tuning in, we'll be talking a bunch about acceptance and going forward from acknowledging the place where you are. So this is an overview of what we'll be discussing today. I'm doing the first part, followed by Angela with strategies for success as a caregiver, and then we have a panel discussion. This slide shows the sources of support for my work. And here is how we developed this webinar. We began by informally surveying the Lewy Body Dementia Association Caregiver Advisory Group. And I started a written correspondence about key issues for the webinar, and we met on the phone and had a discussion. And after that, I confirmed that what we were thinking as important topics for this webinar were consistent with what's published in the literature. And I'm listing here just a sample of those publications. The Lewy Body Dementia Association survey can be found on the website, and it is an excellent document. Really great job to your organization for doing that work. And there have been several publications that have come from it. The first one I list here by Leggett looked at types of burden and found that most Lewy body dementia caregivers experience what's called role strain. We will talk more as the hour goes on about what role strain is. Dr. Gavlin also looked at this survey and reported that in order to get a diagnosis, an accurate diagnosis of Lewy body dementia, patients with their family caregiver had to see, more than half of the time, patients had to see more than 3 doctors over more than 10 visits over the course of a year. So really, typically, it's taking quite a long time to get an accurate diagnosis, and this can be quite stressful. And as Lee has reported, there is greater stress being a caregiver for someone with Lewy body dementia or Parkinson's disease compared with caring for someone with, say, Alzheimer's disease. And then just last month, Rongve, with work out of Norway, reported that individuals with Lewy body dementia become nursing home residents typically 2 years earlier than individuals with Alzheimer's disease. So these publications are all consistent with what we decided to include in the webinar. And these were the topics that we came up with. The themes of our preparatory discussion were advocacy, which relates to how is caregiving for someone with Lewy body dementia different from other types of family caregiving, and planning, and coping. And my presentation is going to focus on advocacy and planning, with a few notes about coping before Angela really dives into detail more so. So, dementia caregiving, what is the big deal about dementia caregiving? There are many positive aspects of caregiving, and I hope we can talk some about those too. It can bring families closer together, though it is the negative factors that get more attention. And one negative issue is that most dementias, including Lewy body dementia, are slowly progressive and they lead towards death. And acknowledging this, that dementia is a terminal condition, this in and of itself can be stressful. And to cope with this stress over time, there have been many interventions that have been studied. I'm using the term here non-pharmacologic, which means not related to medication, treatment and care practices for individuals who are caregivers of people with dementia. There's been a lot of research in this area, and I'm listing just one reference here. And if you are lucky enough to live in a city where one of these programs is available, I would encourage you to take full advantage of it. And the stressors to family caregivers, these do change over time as the illness advances. And early on, the major issue is obtaining an accurate diagnosis. Now, this is a complicated slide. I will walk you through it. First, it's important to know that the type of dementia can only be defined for certain at autopsy, which is after death. And there are tests that are being developed to improve the detection of Alzheimer's disease, and this will help Lewy body dementia because patients will go for testing and they will test negative for Alzheimer's disease. And Alzheimer's disease is caused by one type of brain change, and Lewy body dementia is caused by a different type of brain change that's similar to what happens in Parkinson's disease, but not the same as Parkinson's disease. And there are many people who can have brain changes that are consistent with both Alzheimer's disease and Lewy body dementia when their brain is looked at autopsy. So it's really not simple, but we do have these solid general clinical criteria, which I will go through here to help you have an understanding. If you begin on the right side of the slide, where it lists AD for Alzheimer's disease, the NIA, National Institute on Aging, and the Alzheimer's Association work group came up with this clinical definition of dementia related to Alzheimer's disease. The primary problem is cognitive symptoms, meaning a memory problem plus one other problem like difficulty with language or planning or attention. And it's probably Alzheimer's disease if those core memory and other symptoms have a gradual onset and they progress slowly and gradually over time. And the certainty of this diagnosis of Alzheimer's disease is increased if there's documentation of that decline by some type of memory testing, or if there's genes. There are several genes that are related to Alzheimer's disease. If those are shown to be positive, that increases the likelihood of the problems that that person is having being caused by Alzheimer's disease. And then if you look on the left side of the slide, the McKeith criteria are what are used to characterize Lewy body dementia or describe a diagnosis of Lewy body dementia. And the central features are the same or very similar to Alzheimer's disease, that there's a progressive decline over time in memory or other factors, memory, attention, language, planning. But then there are core features that are necessary to make the diagnosis of Lewy body dementia, and these are much more common for an individual who has Lewy body dementia compared with someone who has Alzheimer's disease. And these include fluctuations, which is a change in symptoms over time. It can be during a day or over the course of a week. Visual hallucinations, which is seeing things that are not real. And Parkinsonism, which is trouble with movements, either stiffness or tremor. And these features are common and are core features of dementia related to Lewy body disease. And other features that happen more commonly for someone with Lewy body dementia are issues related to sleep and sensitivity to many medications, but particularly this type neuroleptics, which are antipsychotic medications which are used to treat hallucinations. And then there are supportive features that happen also more commonly in Lewy body dementia related to frequent falls, fainting spells, changes in blood pressure. And delusions and depression, they are really common in both, but can add support to the diagnosis of Lewy body dementia. So, why is it important to have an accurate diagnosis of Lewy body dementia? It's really because treating the symptoms of Lewy body dementia is different than treating Alzheimer's disease or Parkinson's disease. For example, antipsychotic medication for visual hallucinations may be helpful in Alzheimer's disease, but depending on which type of antipsychotic medication is used in Lewy body dementia, they can be harmful. And similarly, dopamine medication, which is the mainstay of treatment for the slow movements in Parkinson's disease, may be of considerable help in Parkinson's disease, but may not be of help in Lewy body dementia. And because of the fluctuations that people with Lewy body dementia experience, it may appear to a clinician to be a type of delirium. And delirium is a medical condition, and the first step in working with delirium is to assess for the medical cause of the delirium. Delirium is an acute confusional state, and assessing for delirium requires many tests. And when one is getting different tests from different providers, this can become quite stressful. So, how does a caregiver manage this burdensome process of going through the steps of care, of getting a diagnosis and moving forward? I would say that the caregiver, it is of the utmost importance to begin with caring for yourself. And that's the first thing that's listed here because of its importance. This role strain is the largest part of the burden and difficulty that caregivers experience. It is challenging to balance self-care with looking after an ill spouse or a parent or your child. But if you yourself are in need of help, then you will not be able to do the work of caregiving. And if you feel that you have the resources, that you are supported yourself, then you can move forward with next steps of making care plan goals. And I'm listing here, I'll go through being prepared for an emergency and having short-term goals and long-term goals. And if your loved one is in a nursing home, this is a standard to have a care plan and to have it reviewed every 3 to 6 months. And if your loved one is not in a nursing home, you can think about how you yourself might write down a set of ideas that you would look at with people who are helping you every 3 to 6 months. And what you would want in your care plan is really an assessment of what the current issues are for your loved one, plus what action steps are you taking related to those issues. And you can begin by being ready for any urgent medical visits. And you can be ready by simply having an up-to-date list of medications and a health history. I'm describing this as emergency preparedness, but it's really just being ready if there's a new issue and how you would respond to that new issue without having to backtrack a bit. So you can have this medication list ready and a health history. And it's not really over-prepared to have bags set aside that have duplicate items for yourself and for your loved one, and you would want to think ahead about if there's a crisis, where would you go, who would you call, who would you have as the first person that you would call, and does that person have the list of the other phone numbers of people that are helping you so that you could just hand it off to one other person and then they can back you up. So that's emergency preparedness. And for short-term goals, they're not that complicated. You would want to have open communication with the people who are helping you, and when you can find one clinician that you trust, that's a really important step, and it's really a short-term goal. One clinician who's knowledgeable about Lewy body dementia, and then some resources to answer questions, which can be the Lewy Body Dementia Association or some local resources. And with that in place, you then can go forward step by step, really, with more long-term planning issues. But this is really all that's necessary for short-term goals in your plan. And for long-term goals, over the long term, your clinician is where you would go for help with treatments, be they medication treatments or non-medication treatments. You would want to plan ahead about activities, housing, finances, end-of-life decision-making. These are all complicated issues and really take time to sort out. You would want to have a power of attorney for health that's on record. And this is the one slide that I will show about coping. And I would begin with coping. If it's an emergency situation and you notice that, you would then activate your emergency plan. But most of the time it will not be an emergency, but you'll be feeling under role strain. And so then if it's not an emergency, you can ask yourself, am I close to my limits? Do I need more help than what I have? How would I go about looking for that additional help? We found that in the crisis situation, when someone with dementia is in the psychiatric hospital, that 2/3 of family caregivers are at risk for depressive syndrome. So we know that this depression syndrome is a potential problem. But there are ways of managing depression and of coping, and one of the key factors is developing an acceptance and not trying to fight against the situation that you're in. So acceptance is a very important coping strategy, and ways that you can be accepting of yourself is if it is an emergency, you can notice that it's an emergency and feel that you're doing what's necessary to manage that emergency. And if it's not an emergency, and if you're basically okay, you can say to yourself, this is not an emergency, and I know that I'm basically okay. And you can acknowledge that resources are limited, and that illness and suffering exist, and that Lewy body dementia is not a curable condition, but there are things that can be done now, and beginning with what's in front of you is the place to start. And with that, I will pass it on to Angela.
Okay. Thank you very much, Dr. Epstein-Lubow, and I really appreciate you inviting me to present along with you. As Elizabeth said at the start, my section of the presentation is based on my experience as an LBD caregiver for my father, and also for the past 9 years of working with LBD families in my role at Lbda. Before I get started, I'm going to apologize. I have a very unpleasant cough that's been bothering me, and I hope that it will not intrude. So I will have a cough drop, but again, I apologize if it intrudes into our webinar today. So I want to talk first about prevention, because I think as a caregiver, that's really the thing that we rarely think about, is making our job easier by looking down the road a bit. Sometimes we're really preoccupied with what's happening right now, and we don't give second thought to what we might be able to avoid from happening in the first place if we just took a little preventative measure. So first, we still want to start about safety, because LBD is progressive, The person is going to have changing abilities over time, and you're going to have to be prepared to make some changes. So considering them in advance is a really helpful start. And we'll start with talking about driving. Driving can become unsafe in LBD rather early in the disease, and depending upon the person, it might be for a different reason. People with LBD don't experience the same symptom patterns of onset or the same severity. So for some people, they might have pretty severe Parkinsonism, which makes their movements slower or stiff and might make driving unsafe. Other people, it might be visual hallucinations or visual spatial issues that make their driving unsafe because of the way they might respond to something they see or perceive. We all appreciate the ability to drive, and it's really important from a family caregiving standpoint to appreciate how hard it must be for somebody to give up their right to drive. The reality, though, is that not everybody has the same ability to interpret their own level of decline and whether or not they are still safe to continue to drive. So the family caregiver often has to make the decision that this person really has progressed significantly enough in their illness that there are concerns and that they should stop driving. I will tell you that from my personal experience, when I really looked at my father's abilities, I knew we were at that point when I was no longer comfortable having him drive with my children in the car. That was a big indicator. It's not just about their own safety, but the safety of everybody else on the road and their passengers. You also want to look at their home environment. What kinds of things can you do that might minimize the risk of injury or behavioral issues? So lighting, for example, is something that most people don't really think of. You know, we're all used to functioning in our homes with moderate amounts of light. But for a person with LBD, they might misinterpret shadows to be something like an object or a person. And so lighting can cause safety issues, not just because they can't see clearly where they're going, but from a behavioral standpoint as well. It makes life a little bit better to make sure that the lighting is appropriate for them. Stairs are an issue. Due to the Parkinsonism, again, stiffness, rigidity, balance problems might cause a falling problem with the stairs. Also just basic confusion. So for some people, you might have to consider whether or not a single floor residence is appropriate, or is there a safety mechanism you can put in front of the stairs like a gate or even a doorway. Throw rugs can be a real tripping hazard, especially as somebody's gait or walk changes, and so you might want to look to see where they can be removed. And also you want to install grab bars, especially in the bathroom, in key places like beside the toilet or in the shower, so that as they're moving onto and off of different areas or into and out of the shower, they have an extra place to grab hold. So as caregivers, we have to learn two very important things. First, we have to learn to ask for help, and we have to learn to accept that help that's offered or that we have asked for in the first place. That's not always easy. So you want to look for those people who are around you who you can ask for help or who are already offering to give you a hand. Immediate family members can be a really great help with the day-to-day caregiving duties, from personal care to taking them to the doctor, or even looking in your community for other resources that you might need or services that you might want to use. Friends and neighbors can be a great resource for some additional social stimulation for the person with LBD, and to just come sit and stay and visit with them for a while, which gives you an opportunity as a caregiver to take some time for yourself. And that time can be used in a variety of ways, from resting to taking care of yourself to taking care of caregiving or other household responsibilities. So don't look at it as, I have to go to the store. That's the only reason that I can ask somebody for help. Sometimes help comes just so that you can take a nap. And the other thing that you might want to look at are community volunteers. There are organizations such as your place of worship that may offer some volunteer resources to you, again, for simple things like preparing a meal or helping you run it with an errand or taking somebody to the doctor. Don't forget to look at those. In addition to your family and friends, there are some professionals and services that you really should consider as an LBD caregiver. I know a lot of us don't really like to invite people into our homes if we don't know them. It's an unfamiliar situation, and truthfully, sometimes cost is prohibitive. However, it can really make a big difference to your own health and to the quality of the care for the person with LBD, and it can help them stay in their home longer. So we really encourage you to think about some of these things. Depending upon your situation, one or all of these might be helpful to you. So meal services, something like Meals on Wheels, can bring hot meals to the family or to the person with LBD and their primary caregiver, on a daily or near daily basis. For people who are living alone, who are still in early LBD, they may already be having some problems using appliances or knowing how to do some things. So this can really give them a little bit additional measure of independence. Adult day programs are a real benefit, and there was a recent study that came out about how this really is improving the caregiver levels of stress, not just emotionally, but even at a physiological level. So adult day programs provide people with LBD a social place to go during the day where they have structured activities and they get to see a variety of faces, but also gives the caregiver, again, that added support so that they can take care of some other things. Home health aides are really great for personal assistance in the home, like bathing, making some meals, doing light chores. A geriatric care manager or case manager can be helpful, especially to long-distance caregivers, but they also can provide help to other people who are dealing with challenges and situations that they just don't have the answers to. They're professionals in the aging field. They might be social workers or counselors or gerontologists, but they can help refer you to other resources in your community and help you really deal with some stressful situations. Long-term care, not everybody is comfortable with the idea of using long-term care as a resource, but I will tell you that that's sometimes an essential thing for people who are living with LBD, and we'll talk about that a little bit later. And then the last item really are caregiver support groups. We as LBD caregivers need a safe place to go and share our struggles, to hear from other families, to know that we're not alone. So look in your community for caregiver support groups. Next, I want to talk about adjusting expectations. We all want the very best for our loved ones, but what we want, or even what they want versus what they need, aren't always the same thing. So here's some examples of where adjusting expectations for yourself or for them are really important. For example, let's say the person with LBD wants to continue driving a car, and you're now sure that that's no longer safe for them. You're going to have to set boundaries for them, for yourself, for the safety of other people. It might require that you take the keys away or enlist a doctor's help to convince them why driving is no longer safe. You might need to disable the vehicle or even sell it. So look at what you need to do to set those boundaries to ensure their safety, even though it may not be something that they are comfortable accepting. They may want your attention or your presence all the time or at inconvenient times. They may not be able to pick up on subtle social clues when you're not available. So you may have to look at explaining to them that your needs, that you need some space, you might need some time for rest, that you've provided them with an alternative person to visit with or whatnot, but make sure that you put yourself as an equally important person in that relationship with the person with LBD, and that you get some time for yourself. And then the last thing is the situation with living arrangements. As LBD progresses, some people are going to need more caregiving support than one person can reasonably provide. We're talking movement changes, cognitive changes, behavioral changes, other medical situations that may make caregiving more difficult. But as caregivers, we can struggle with that decision to admit our loved one to long-term care because we feel that there's nobody else who's going to do as good a job or will care as much as we do about taking care of them. But it's important. We have to balance our own, their needs rather, with our own, and make the decision in our favor occasionally if we are really becoming physically or emotionally depleted. Long-term care provides fresh, rotating shifts of staff 3 times a day. And there's simply no way that we as individual caregivers can meet that level of same care at home by ourselves. So you have to look at whether what you're able to do independently or with some additional help at home really is meeting their needs, even if it emotionally is meeting your needs or their needs, but not their caregiving needs and their medical needs. And the really good news about long-term care is that your role as caregiver does not end. You actually get to transition your role from, instead of doing the hands-on, day-to-day caregiving, to actually looking more at quality of life issues, social issues, emotional support, and that's a win for both people in that equation. And then the last thing I want to talk about is you as the caregiver, making sure that you remember how important you are in their life. If something were to happen to you physically, emotionally, where would they be? You have to make yourself a priority. When family members transition from being a spouse or an adult child to becoming a caregiver of someone with LBD, that can happen slowly, little by little. You may not be aware that you're actually starting to take a larger role. Or it can happen because there was a crisis. Somebody had an accident or got lost, or there was a medical situation that really revealed the true depth of what their current abilities are and the changes that have happened. In that case, it's very easy to get caught up in crisis mode and to forget that we can't maintain our current pace for very long without completely exhausting ourselves. So we have to be able to step back occasionally and ask ourselves very difficult questions. If I'm going to be a caregiver for years to come and not just weeks or months, what changes do I have to do today in order to be able to sustain this pace? What am I going to need to lay as far as a foundation goes for the long term? You also want to see your doctor regularly. It's far too easy to put our own health on the back burner when we're just dealing with little things while we're caring for somebody with LBD. We may think that our needs, medical needs, are minor, but what we don't realize is that they can compound over time. Let's talk about exercise too. It's not just good for your waistline. It really helps you manage your stress level. Chronic stress can affect your immune system, and that can lead to increased illnesses. So simply going for a walk on a daily basis is a really great way for you to manage your stress, give yourself a little breathing space, a little time to think, a little time to let the weight come off of your shoulders. It doesn't have to be very time-consuming. It doesn't have to require any expensive equipment. But get out and move, whatever you can do for yourself there. A healthy diet, again, provides more than just nutritional benefits, but that also can improve your energy level. You know, if we're snacking on things that are high-calorie, high-fat, we're not getting good nutrition, that just saps our energy, and the lower our energy goes, the lower our ability to deal with the simple frustrations that come along with life and caregiving for somebody with LBD. So make sure that you're looking at not just exercise, but diet. And sleep, I can't overemphasize sleep enough. Your bodies, your brain, your mood, they all need sleep to rejuvenate. And truthfully, when we're exhausted, we become cranky caregivers. And studies show that our own mood as a caregiver can be reflected back to us in the behavior of the people we're providing care. With LBD, because it's already fraught with some behavioral challenges from time to time, you don't want to make your own challenges more difficult. So make sure that you're protecting yourself as much as you can by taking care of yourself. However, the other side of this equation when we don't take care of ourselves is caregiver burnout. That's really burning the candles at both ends until you wake up one day and you just think, I cannot do this for one more day. You're physically and emotionally completely depleted. So look for these warning signs and talk to your doctor about your level of stress and whether there's any warning signs of depression. Withdrawal from family and friends, even when you have the time to spend with them, can be a warning sign. You just might not have the energy to engage with them. if you're feeling blue or you're increasingly sad or you're not finding joy in the things that you normally enjoyed, that's a red flag. If you're waking up in the middle of the night or you're having problems going to sleep or you're falling asleep but waking up frequently or even earlier than normal, that's a sleep pattern change, and you want to talk to your doctor about it. We've talked about nutrition, but your appetite can wane or you can overeat depending upon how you manage stress, so that's an indicator to keep an eye on. And chronic stress can really affect your immune system, as I said. If you're getting sick more frequently, that's something to be concerned about, and go and see your doctor about it. I mentioned what it feels like when you're burning the candles at both ends and you just think, it's not going to take much for the one more straw to break the camel's back. That level of emotional exhaustion, you can't sustain, and you shouldn't. So make sure that if you find yourself getting easily frustrated, you're more irritable than normal, you're exhausted, and any of these other indicators are coming up, that you go and see the doctor. And last but not least, I want to talk about what Lbda has for family caregivers, because we're founded by LBD caregivers, and so our earliest programs and services were designed specifically to help us and you find the support that you need. So we have our caregiver link, which is a one-to-one resource that allows you to talk on the phone or through email with an LBDA volunteer who has also been an LBD caregiver. They share their own experience and their practical advice and what they know about the disease, and it's just nice to have one-to-one dialogue sometimes. If you're in a community and you're looking for some face-to-face support, you want to look for a support group and visit our website under Find Support. We have groups growing across the country, and we are always looking for people to come and join us and to start new support groups. We can provide some training to help you get one off the ground. And then last is our online communities. These are a number of different resources, from our discussion panel to an online support group and to our social media outlets, that you can also connect with other families. There's phone, in your community, online, lots of ways for you to find support that you need. So please visit our website. And that's all I have for my side of the presentation.
Okay, great. Well, thank you very much to both of our panelists for their informative presentation. And I just would like to take this opportunity to let our LBD caregiver panelists introduce themselves. I know that one of them, Janet, may not have audio, but I will check in with her to see if she does when we get to her. But I first want to introduce Norma Loeb, who is our Board of Directors member and is also an LBD caregiver. So Norma, thank you so much for coming, and can you tell us a little bit more about yourself and your experience with LBD?
Yes, Elizabeth, thank you. I have been a caregiver for my mother for almost 15 years. She's had almost every symptom and every stage of the disease over these years, very slowly, but almost every single one. She lives with me, and though I have 24-hour care for her, I'm the main caregiver and overseer. I'm also the support group facilitator in New York, so if there were any things that didn't affect my mom, I've heard them from so many other people. So I'm happy to help.
Thank you so much. And Janet, are you able to speak to us? Okay, I'm not sure if her audio is going to work for us. Cecilia Zappa is also an LBD caregiver. Are you able to tell us a little bit more about yourself and your experiences with LBD?
Hello, are you able to hear me?
Yes, thank you.
Okay, great. Well, hello, everyone. My name is Cecilia Harry. My husband, Andrew, and I just moved to the Omaha, Nebraska area, and my father, Pat, has Lewy Body Dementia and was diagnosed about 2 years ago. My family lives in St. Paul, Minnesota. I have two older sisters. My mother is the primary caregiver, and they all live within 10 minutes of each other in the St. Paul area. And then my husband, Andrew, and I are 6 hours away in Omaha. So I have a lot of experience being a long-distance caregiver, and I'll wait till later in the panel to share some of my experiences.
Thank you so much. Well, we have some interesting questions posed to our panelists today, and so we are going to let I will pose the question directly to a panelist, and then we may have one follow-up comment from the rest of our panel. So let's get started. The first question I would say is that someone, their loved one was recently diagnosed with LBD, and their symptoms were evident for 2 years, and over the last 2 years, and Parkinson's more recently. They haven't seen hallucinations except reading a sign or other written material as something that it's not. So is this considered a hallucination? And I'm going to pose this one to Norma, and we may ask Gary to follow up as well.
Okay, Elizabeth, that question, in my experience and listening to others in the group, there are some people, only a few though, that don't have real visual or audio hallucinations. But in my experience, I would say if they're reading signs, I wouldn't call that exactly a hallucination, but I would call that a visual problem, which is also part of LBD. I wouldn't necessarily call that a hallucination, though.
Sure.
And I would agree with what Norma's saying. It's a misperception. And misperceptions, like Norma's saying, are common in Lewy body dementia and in other dementias. It's not as classic as the visual hallucinations of seeing small people or animals, which other caregivers may have noted their loved one to have, but it is supportive of a diagnosis of LBD.
Okay, great. The next question was also that her loved one had RBD, or the sleep disorder, and was having sleep issues, but did not want to really sleep in separate bedrooms. So is there are medications indicated to help him rest? And I'll pose this one to Cecilia.
Yes, this is Cecilia. Honestly, with my father, and still being pretty early on, he's only been diagnosed for 2 years, my parents still share a bed together and have not, my mother hasn't experienced this part of the disease yet, so I'm not sure if I'm the best person to answer that.
I can jump in.
Sure, that'd be great.
Sure, about medication treatments for the sleep behavior problems. It's really case by case. And remind me again, Elizabeth, is the question whether to be sleeping in the same room or not? And then the secondary question about how to treat the problem?
Right, and I think it was mainly that medications to help him rest so that she really can sleep in the same bed still.
Okay. Oh, so that I understand. So the symptoms are making it such that the bed sharing caregiver can't get her own sleep.
Exactly.
Okay. So this is a complex problem, and it goes back to having a clinician that is trusted that can really work with the family about trying different interventions over time, because it's a risk-benefit issue. The medication may be helpful for the symptoms, or because of sensitivities in LBD to medicines, it could make some of the fluctuations worse, depending upon which medicine is tried. So you would want to have that relationship with the individual clinician so that you could get an answer about what medication they would want to try and how long they would want to try it for, and then what would be the next steps. That's the best way I can answer a question like that. And it is I'd be interesting to hear a follow-up from that individual about they're wrestling with their own needs, and what would it be like for that person if they accepted that, okay, sleep is difficult, it makes my sleep trouble at night worse, but could we have twin beds or something like that? What's
Right.
a way that I could adapt that would be that wouldn't force a need to have a medication that would change the symptom for the patient?
Wonderful. Okay, we've gotten a lot of great questions here. One is on wandering, and they want to know if getting lost in a familiar environment is a sign of LBD. Walking home on a common path, my dad has gotten lost twice. So Norma, would you like to field this one?
That particular instance I didn't personally experience with my mom, but I would say that confusion could definitely that would definitely be a sign of it. As when they can't find their way, things look similar, or they can think they're on the same street, on the next street. If things look similar, it would be a very common thing to happen, to get lost. I don't know if I answered the whole question, but it's certainly a sign.
Definitely.
Can I just ask a follow-up to Norma?
Certainly.
What would you say to that caregiver who's worried about their loved one getting lost? Like, what can the caregiver do with that worry about, I'm worried that my loved one is getting lost when they're out walking?
Well, as soon as you hear that once, especially if you hear it twice, then that person should no longer be walking outside by themselves. As long as, if you have any control over that situation at all, they shouldn't be out alone walking, because it would be really easy to get lost and very confused.
Okay.
And oh, sorry, Elizabeth.
No, go ahead.
I was just going to raise the ID bracelet also, and an assessment, because they're asking a great question about, is this a sign of a dementia? And really, we can't. I think what I hear Norma saying is that we can't know that, and it goes back to the finding a clinician who you can work with to help you get an accurate diagnosis.
Oh, I'm sorry. I was thinking that this was a person who was already diagnosed with it. Otherwise, I certainly agree.
Yeah, I'm not sure from the question. It just says that is it a sign of an LBD? So maybe they still haven't gotten that definitive diagnosis yet.
Mm-hmm.
All right. Well, I've gotten a couple of great questions about having trouble coping with communication, and also another person that has a loved one that understands, but words are not possible. Cecilia, can you talk a little bit about communication and maybe tips for people that are having those communication issues?
And are you referring to when the loved one is having a hard time communicating their feelings, or back and forth?
It sounds like back and forth in one situation, and then one is really getting that communication back from the person with LBD.
Okay. And again, I just want to preface that my father is still in early stages of the disease. So
Sure.
I think the hard part, or maybe something to comment on that I think we've all experienced, regardless of where our loved one is in the progression of the disease, is that there will be various stages of grieving each change in communication with the loved one. And so with my father still in early stages, it's actually been a lovely thing that he likes to pick up the phone and call my husband and me more frequently than in the past. And so it's been nice to have that kind of chatty relationship with my dad that I never had, nor did I want growing up, but it's something that I very much appreciate having with him now. But when I realized I couldn't talk politics with my dad anymore, I had to kind of grieve that, because it wasn't fair to engage him in those sort of heated discussions or debates when he couldn't find the right words and wasn't able to defend his view in the way that he had before. And so that was something that I had to grieve. And when the phone conversations are very one-sided, he doesn't always ask a lot of questions anymore. It's more about him telling me about his day or about what's bothering him. And so he doesn't quite have the same interest in what's actually going on with me anymore. And so I had to grieve that. And then just probably the biggest thing that I'm struggling with now with my dad is that he's still very high functioning, but he's not capable of computing things the way that he used to. And so that's tough in terms of trying to find ways to let my dad know what's going on about a family member or an event or something like that in a way that includes him and honors him as a person without frustrating him or upsetting him because he either can't process what I'm trying to communicate or I don't want him to pick up on that I'm not being truthful with him about something or something like that. So that's something that I really struggle with now. But in terms of him being he's very able to express his needs still. He goes to a sort of classroom sort of program once a week and enjoys it tremendously. But there's been other programs that he's been enrolled in that he did not like. And so he's still able to communicate physical discomfort, things that upset him and bother him, things he likes and things he doesn't like. So in terms of understanding if we're meeting his basic needs and addressing his concerns, we're still able to do that with my father. So I'm not sure how much that helps when it gets to a point. I don't have any direct experience with what I know will eventually come, which is grieving a loss of some of these forms of communication as well.
This is Norma. I'd like to make a quick suggestion for people who are having difficulty in speaking to someone. What helps quite often is to make the question as simple as possible and wait. Don't be anxious that the person hasn't answered immediately, because it takes time, a little bit longer for them to understand the question. And I have found that touching the hand, touching the arm as you speak gets their attention as well, and just have patience in getting the answer back.
Great tips, definitely. We have had lots of good questions here. I would say a couple have been about personality changes and behavioral changes that something would make a normally easygoing person become combative or negative. Norma, can you address also a little bit more about behavioral changes in people with LBD?
And Elizabeth, are you asking specifically what can be done to help that? Was that really the question?
Yes, and is it a common thing for people with LBD?
Okay,
in general?
Thank you. It's absolutely common. I would say that it happens probably mid-stage, but it could happen at different stages with people. And I also want to say that many times, particularly with this and with other symptoms that happen, they can go through a stage and then at some point that particular stage stops. And so that if they were aggressive at one point, it could be that a few months down the road or possibly a year, that person won't be aggressive anymore and something else may happen. But I just wanted people to know that not every single symptom stays the same all the time. But with the aggression, and if someone gets angry, it's a very common symptom in LBD as well as with other dementias. And I want to suggest when someone gets that way, please do not argue with them. The best way to handle that situation is to either agree with them about what they see as wrong, or better and best yet, is to say in a very calm manner, that you will take care of whatever situation is bothering them. So, for instance, if they saw bugs on the floor and they're getting upset about that, say, I'm going to take the bugs, I'm going to clean the floor right now and take care of it. Sometimes they see people in the house, which upsets them and is scary to them. I'm going to let them out the door right now. You open the door, you ask the people to leave, and you become part of what they see in their reality, because to them it is real. And it's the only way that helps that frustration to subside. And in line with this, I want to stress that the emotion and energy that you have makes a big difference around them. So if you're angry and stressed and frustrated, it makes them worse. So to be as calm around them as possible, particularly when they get in that type of mode. Or you can walk away and come back and try to change the subject and redirect it. That's another way to deal with it.
Okay, great. All right. If I have several more questions to field, but I would say the most prevalent one, of course, is medication-related questions. One, and this may be something that Gary can kind of field quickly before we close. Someone had stopped Aricept and gone to the Exelon patch, and their loved one's speech and walk changed after following this. They are seeing a doctor next week, but would stopping Aricept have an adverse reaction? And what are typical medications, I would say, and also medications to avoid, which is another kind of big topic. And we may not have time for all that.
Yeah. So starting with the last question first, medications to avoid in Lewy body dementia. The classic ones are all antipsychotics except for two. So if you ever hear a recommendation for an antipsychotic called quetiapine or Seroquel, that's not out of the question in Lewy body dementia. And similarly, an antipsychotic called Clozapine or Clozaril. It will come up if your loved one has hallucinations or intense paranoia or suspiciousness. And the other antipsychotics can make the movement symptoms worse and can make some of the cognitive problems worse. And then in general, people with Lewy body dementia are sensitive to medications, the medications that act on the brain. They have a vulnerable brain. So the one example that's asked is, can a change in Aricept, I forget if is it discontinuation stopping Aricept? Can that make symptoms worse? That's the question. In general, the stopping of any medicine that is acting on the brain that is a memory enhancer, yes, it can stopping it can have a negative effect. But it is hard to know. Aricept is not approved for the use in, or I can say what it is approved. It is approved for use in Alzheimer's disease.
Right. Well, I guess we should probably wrap up since we are 1 minute till. But I want to thank everyone for all of your questions, and there were many that we didn't get to. If you'd like to pose questions to our panelists following the webinar, if you could please send them to lbda@lbda.org, and we'll make sure that those questions are answered as well. We are recording this session, so we will have it on our website for you to refer to later or pass it on. So thank you all so much for your participation today, and thank you so much to our panelists. And we will end now. Please visit us on lbda.org for more information and to sign up for our e-newsletter. And our caregiver link line is there as well. Thank you very much.